The third theory that will offer underpinnings for what we go over in the course is the self-determination theory. This theory really examines the motivation behind a patient's ability to get through rehabilitation, the hardiness, the resilience, the motivated behavior, as well as encapsulates psychological health and well-being and task-related performance. There are three major tenets that the theory holds, and those are competence, relatedness, and autonomy. And the individual needs to be connected on those three levels in order to succeed, in order to be motivated to pursue or to be resilient in an act. When those are met, as you can see down here, psychological health and well-being improves, internal motivation improves, and performance improves. When they're not met, an increase in apathy, alienation, stress, and anxiety. So you can see here, if you apply the cognitive appraisal model over this, here you're going to meet your rehab goals, here you're likely not going to meet your rehab goals. So let's talk about competence relatedness and autonomy and typical athlete concerns that fall into those categories throughout the rehabilitation process. So competence, re-injury anxiety, reach pre-injury levels of function, fitness levels, role on the team, up to speed on plays, strategies, new strategies that the team has formed while you've been out. Relatedness really factors in isolation, being away from that team setting in the locker room, etc. Identity, if that's the only hat they wear, that athlete hat, now that's sort of gone or hung up on the rack. How do they perceive themselves? And then social support also falls in relatedness. The final category, autonomy, pressures to return to sport. The world is on their shoulders, so to speak. Regarding competence, we want to look at tools, again, applying these theories as a clinician, like how does this theory really assist me? Look at tools and resources to increase competence. That's how we as clinicians are able to intervene on behalf of this theory, on behalf of the athlete utilizing this theory. So think about re-injury anxiety, pre-injury levels, fitness, role on the team, strategy, etc. We've got imagery modeling, relaxation. We've got goal setting, cardio workouts, functional progressions to really show that athlete, that patient, that they're making those strides, they're becoming better. And then education has been shown to decrease anxiety, to improve motivation toward a goal when you're setting goals, to really frame that progress, to chart that progress through functional progressions. So again, tools and resources. There are some apps, especially goal setting here, that are extremely effective because they involve imagery. And if no one finds that one and posts it, I'll definitely do that for you. Here's the evidence on patient education. As I mentioned, stress and anxiety from lack of education. That's in 2011. From our textbooks, patients want to be educated by the care provider. That's an expectation that athletes have. And can we predict a patient's needs? Yes, we can, for the most part. A first-time injured male athlete is at highest risk. That's from Dr. Clement. He's speaking to you in this course as well. And then females versus males, same study. Females need different things compared to their male counterparts. So read that in the textbook to highlight yourself on that. And then positive environment, again, the Russell and Tracy article, and communication. Those are patient expectations, that we foster that positive environment and we communicate with them in a positive way. And then cultural differences do exist in expectations. And that's an article by Dr. Averam Barrow, who already spoke to you in your course. If you have not listened to her, she'll be talking to you later. The evidence on goal setting suggests that the autonomy-supported behaviors of the clinician are associated with the athlete's motivation. And this also relates to adherence to rehab. So if we can get that athlete involved in the goal-setting process, they're more invested, they're more likely to be compliant and adherent. The second bit of data here, the protection motivation theory, and it's kind of a classic study, so 1996, we're okay with that date in this case. Athletes are motivated to adhere when they believe that rehab will be effective. So here's an efficacy of care study if you're interested in that. Research in support of self-talk. An individual self-talk can affect both how they think and feel. If some of you don't know a lot about self-talk, 1982 is sort of an ancient but historical study. And then positive self-talk outperformed negative self-talk in control groups on sports skills. And a lot of people doing some work there, initial groundwork there. And then Athlete developing own self-talk script is more effective in performance gains, 1988. A lot of this research too can stand for some replication if you're interested in doing something like this for a dissertation topic or even a master's thesis. When looking at mental imagery, relaxation, and pain management, imagery relaxation scripts can lower blood cortisol levels in one 15-minute session. That's work that I did with Michelle Dawson, my master's student, when I was at Weber State. Very interesting study, and the effect of just using an app, a relaxation app for 15 minutes, we're lowering that saliva cortisol level. And cortisol is, if you watch the TED Talk, related to the stress perception that we have. Imagery involves relaxation, which has been shown to reduce muscle spasm and improve blood perfusion. Again, a historical study here. So sort of Benson having the foundational examination of healing mental imagery. And then the final study showcased here, the effectiveness of 3 imagery scripts on pain tolerance found the more stimulus that we give the individual, the better able they are to be distracted from their pain. So in this case, talking to them, having music and a visual was best to distract them from their pain. So think about this when you apply it in the clinical setting or when you're looking for an app that facilitates pain management. Spirituality, I did want to touch on this. If you're in the cultural competency class, you're getting a little dose of it there as well. When assessing ATP curriculums, only 5% currently offer a course that relates to spirituality in the curriculum. However, look at the majority of PDs believe it's important and should be addressed. The important feature that I want to point out here is I'm not taking a side with this research. What I'm doing is pointing out to you that each athlete or patient is going to require a different set of tools. So you knowing that individual, getting to know that patient, you'll know what set of tools to offer them. And if they reference God a lot, if they reference a higher being, if they say they're going to pray about their pain, then maybe you want to introduce to them some spiritual affirmations or even a Bible app or something of that nature, or show them a host of different spirituality apps and let them select. The second element of the 3 tenets of the self-determination theory is relatedness, and that's team isolation, identity, and social support. Interventions here, I think the drive-by with the coach, making sure the coach is driving by, so to speak, the athletic training room or a clinic setting to facilitate communication with that athlete. You as a clinician communicating with the physician of that patient or the athletic trainer of that patient or the coach of that patient, developing those communication lines and knitting everyone closely together to form that support net for the athletes is crucial. It's very important. If you can involve team members in the rehabilitation in any way, that would be excellent. When I worked in Chicago at Athletico and we had a Chicago Fire MLS athlete come in, oftentimes we would request a pair, not just one, 2, to come in and work together, even if one was injured and one was not. And then mobilizing the social support network as a tool, making sure athletes and patients know who's out there, who they can reach out to for support. Social support network might look something like this. I already talked about the drive-by. Communication is important, involving team members before and after practice. If you're in a college setting and you can do rehabilitation during practice and allow that patient athlete to talk to their teammates before and after practice, that's excellent. There are also Facebook support groups, and I would be careful. Here you just have a slice of injured athlete support groups. There are also pain support groups. There are specific pathology support groups like post-polio groups, fibromyalgia groups, and the like. So please, before you recommend these to a patient, please go ahead and moderate those for a couple of months before you're comfortable to suggest something like this to a patient, just to make sure that it's legitimate and you like the vibe that's going on there. The last tenet of the theory is autonomy, and this is the pressure to return to sport. So I really think here focus is the key. Keeping the athlete, patient focused on what they have overcome, keeping them focused on their goals yet to achieve, and understanding that they will have the pressures and providing coping skills or talking about how to disseminate those pressures, or how to dissolve those pressures around them, and really stay focused on the goal at hand and the autonomy to reach that goal. They're really the driver of the car in that case. So focusing on that. That wraps up the self-determination theory. Again, competence, relatedness, and autonomy being the three major tenets of that theory. And I provided examples of tools to use as a clinician to really reach out to that athlete and to improve those. Remember, when we improve those three things for the patient, their chances of rehabilitating fully and completely in the best shape possible, we're optimizing that process.